My observation was that doctors were not using this gold standard medication for clearly treatment-resistant cases, individuals who had trialed not one, not two, but 3, 4, 5, sometimes 10 antipsychotics before being placed on clozapine.
I haven't heard any of them talk about clozapine with any sort of stigma. I've heard them talk freely about it and how it can be used, but I haven't heard anyone talk about the restrictions or how difficult it is on patients. Hello, and welcome to the Self Disclosed Podcast. I'm your host, Patrick Gilligan, and today I spoke with Rachel Streiff, who is an advocate for individuals living with serious mental illness and their families. Specifically, she's fighting for access to an antipsychotic medication called Clozapine, which is used for treatment-resistant schizophrenia patients. Rachel is affiliated with a host of different advocacy groups. One she talked about today is the Angry Moms, which is a group of families coming together to make an effort to remove some of the FDA's regulatory barriers to access clozapine. This is a really, really interesting podcast. Rachel is an expert in this topic, and if you want to go deep, I'll link in the show notes more about where you can find her work and where you can support. She is trying to raise awareness for an FDA ballot coming up in November, so if you're passionate about this topic after hearing the podcast, click on the link in the show notes and support her work. Without further ado, here we go. Awesome. Rachel, thanks so much for being here. So excited to talk with you.
Great. I'm happy to be here.
Sweet. So maybe we can just start off a little bit about your journey and sort of how you ended up being so, passionate about schizophrenia and clozapine and just getting to the message that you're trying to put out today.
Yes. So I became involved in the clozapine community after a family member required clozapine for treatment for schizoaffective disorder. I've also since become a legal guardian for a young woman who is 31 years old, and she also has severe treatment-resistant schizophrenia, and she's also benefiting from clozapine treatment. My observation was that doctors were not using this gold standard medication for clearly treatment-resistant cases, individuals who had trialed not one, not two, but 3, 4, 5, sometimes 10 antipsychotics before being placed on clozapine, and that's not the standard of care. One issue with this serious underutilization and delay in treating people with clozapine is what we call the Clozapine REMS, the FDA's Risk Evaluation and Mitigation Strategy for clozapine. It's been so eye-opening to see how a regulatory barrier so negatively impacts a patient population, anywhere from doctors hesitating to prescribe it to sort of a stigma or idea that this medication is extremely dangerous. The language last resort is used to describe clozapine, even though that's not the current guideline, and it never really was the guideline. And probably the most tragic element of this REMS program is that there is only one medication that has ever received an indication to prevent suicide. Not an antidepressant, not any mood stabilizer, but clozapine. To this day, it's the only medication in history that the FDA has ever recognized with a formal indication to prevent suicide.
So can you tell me about REMS and what is the actual mechanism that has prevented this from being standard of care?
So when clozapine was first released in U.S. markets in 1989, there was concern about a rare side effect called severe neutropenia, which is when neutrophil counts plummet well below a healthy limit and individuals are at risk of having infections, and it can be potentially fatal if it's not detected. So when clozapine first came out, it was released with a weekly blood test to measure neutrophil count, or ANC, which stands for absolute neutrophil count. And that was done weekly as a way of trying to prevent and detect cases of neutropenia before they became serious. it was intended as a temporary program. Unfortunately, clozapine lost its patent, lost really its champion, and that particular restriction was never really dealt with. The FDA did loosen some of the testing frequency requirements. So, for example, patients went to every 2 weeks testing after 6 months, and then eventually went to monthly testing after 1 year as the guidance. But a particularly damaging thing happened in 2015. The FDA implemented this, I would call it, electronic surveillance platform, where instead of individual manufacturers tracking their own patients and monitoring the new ANC counts and measurements that they would get every week, there was this surveillance platform that is a centralized database to report ANC for patients. And it's called REMS, like I said, but it also has something called an ETASU, Element to Assure Safe Use. And how the program works is that it blocks refills of prescriptions if someone doesn't have a current ANC in the system. And okay, so imagine if you had diabetes, for example, and your life depended on insulin. Imagine if you were only given 1 week of insulin at a time, and that you had to go to a lab, get a full blood draw, and produce a paper that said you still have diabetes before the pharmacy would be allowed to dispense your week ration of insulin. Imagine how difficult that would be and how dangerous. And with clozapine, 1 day without clozapine has well-documented risk of relapse. In fact, the clozapine label itself has a 24-hour rule where intervention has to take place if a patient even goes 1 day without it. So it's not a medication that you can miss doses. And here we have weekly rationing of pills and the requirement for a full blood draw to be accomplished, the lab report make it to the doctor enter it in the database, and then the pharmacist know how to use the system and then dispense the medication. So all these problems are constantly going wrong with people having access to just their basic refill of the medication.
Was there an extreme set of cases that caused this reaction to, and I'm probably going to pronounce it wrong, but neutropenia?
Neutropenia.
Neutropenia. Was there a reaction to this caused by a set of cases, and maybe do you think the reaction was appropriate or overdone?
Sure, it's a great question. So during the development of clozapine in Finland, there was a cluster event. There were 16 cases of severe neutropenia that occurred in mostly elderly Finnish patients, and 8 of them died. There's quite a bit of mystery surrounding that as to what else might have been going on with those patients, because we haven't seen another cluster event like that since 1975, even in countries that have reduced monitoring compared to the United States. So that really caused a bit of a panic, caused a halting of the development of clozapine, and it didn't make it back until 1989. And that was, of course, with the rigid monitoring in place. So that was what started this, I guess, ongoing nightmare. The problem is that the benefits of clozapine didn't appear until much later. So it was in 2002 that the indication to prevent suicide was discovered through the conclusion of the Intercept study, and that new indication for clozapine came out.
What was the drug originally developed for?
It was originally developed for treatment-resistant schizophrenia. So clozapine is a superior antipsychotic. In fact, if 2 antipsychotics have failed, clozapine is 5 times more effective than the second best. And still today, it's called the gold standard antipsychotic. It's far more effective than anything else that has ever been invented. There is another interesting new bit of information that came out again since 1989, and that is that clozapine significantly reduces mortality. This was discovered in a longitudinal study of 60,000 Finnish patients that clozapine significantly reduced all causes of mortality compared to other antipsychotics and effectively added about 10 years to patients' life. So it's not just the most effective, which was known in 1989, but it's also the safest long-term antipsychotic, and it significantly prevents suicide. In fact, the lifetime risk of suicide in the schizophrenia population is around 5%. Clozapine was found to reduce suicide to that of the general population. So the lives saved by clozapine, just from preventing premature death and suicide and all causes of mortality, are significant. And that came out after the REMS and all this blood testing was put in place, and it never got revisited. And what's happening now is that prescriptions are being interrupted frequently, or patients are not being given clozapine when they should be because of all of this hassle and difficulty with the system and the rigorous monitoring. And the REMS program that was supposed to be intended as a safety program has really become a significant hazard to clozapine patients. For every life allegedly saved by all of this monitoring and this REMS program, hundreds of people die from lack of access to clozapine.
Yeah, it's really interesting just to see how a reaction like this, what the downstream impacts can. And I understand the reaction to a cluster event like that. And I think that is very serious. But, maybe the expected reaction would be implement safeguards and then implement further studies to try to understand what the cluster event was, especially if at the time it was still known to be as effective as it is. I've worked alongside lots of psychiatrists and who are amazing, and I've also gotten the opportunity to talk with a lot of them. And I actually haven't heard any of them talk about clozapine with any sort of stigma. I've heard them talk freely about it and how it can be used, but I haven't heard anyone talk about the restrictions or how difficult it is on patients. Where do you feel like the largest stigmas or barriers to the wider spread use of this drug for treatment-resistant depression and schizophrenia? Where do you feel like that barrier is right now?
It's really in the education and experience. Since only about 10% of people indicated for clozapine ever get it, it's so just rarely used. And you will hear doctors, psychiatrists, I've heard them say, we don't use clozapine here. Or they'll say, well, I've never prescribed it. It's pretty interesting to me that at a master's or PhD level, it's acceptable to not be experienced and proficient in the gold standard for your field.
Sure.
And there's also this, I guess, misperception that other medications are just as good as clozapine. And that's never been true. I think a lot of physicians and practitioners believe that because there's been effective marketing of other antipsychotics, but nothing has compared to the safety and efficacy of clozapine in 50 years. So I think there's significant lack of just understanding and experience with this drug.
Where do you think is the practical next step? If the problem is the restrictions that the FDA has around it due to the REMS program, do you think that the next step is an alteration of that program? Is it a different collection method around the test for that the patients have to take? Like what is the next practical step in your mind?
Yeah. So the very first thing that should happen is to stop enabling pharmacists to block prescription refills. We've encountered a few cases of true clozapine-induced neutropenia that were indeed life-threatening. It can happen. However, not one of those cases were detected or prevented or addressed by someone driving up to a pharmacy window, the REMS blocking their refill, and a pharmacist saying, no, sorry, I can't give you your medicine today. That has never happened. We have the internet now. Doctors get the lab reports when they come in electronically. We can just look it up. All of the patients who've had this reaction, they either were already sick to begin with, already in a hospital, or a doctor or a lab identified the low value and intervened. Not a single case has, not a single life has been saved by this REMS blocking prescription refills. It would appear almost exclusively that the REMS is only blocking refills in people who don't have clozapine-induced neutropenia. There's a tremendous amount of surveillance bias. There's a large rate of false positives, even something as simple as the number is supposed to be 3,000, but on the lab report, it's in thousands, so it says 3.0, and someone types 3.0 in the REMS. That will block a prescription. Just missing a routine lab, now patients have to suffer and be hospitalized and suffer extreme relapse where many don't even recover. It's simply hazardous and not helping anyone. And there currently is no means by the FDA to measure these, what we call regulation-induced adverse events. In fact, there's some indication that when these problems occur because of interruptions, they're being reported to the FDA's adverse event database as affiliated with clozapine, not the REMS blocking the refill. And it just even further contributes to the idea that this is some kind of dangerous drug.
Yeah, that's really interesting. Who would be liable if a patient did have an event of neutropenia and suffered either a mortal event or some serious adverse event? Would it be the doctor prescribing? Is it the drug manufacturer? Like, is there anyone who might have an incentive to make it harder to use the substance?
That's a loaded question, and that's $1 million question. I don't know, but everybody seems to be afraid of liability with this particular adverse event, when instead there should be liability towards interrupted treatment and the consequences. There should be liability toward failing to use clozapine in incarcerated settings or in recurrent suicidal behaviors when it's clearly indicated and nothing else has worked. The field of psychiatry has really failed this population with treatment-resistant schizophrenia, and you see it. Other countries, less developed countries, have reasonable rates of clozapine utilization, where 20 to 35% of the schizophrenia population gets this drug. In the United States, it's like less than 5%. So we are really failing the sickest patients, and it's creating excess disability. It's creating prolonged illness, brain damage from untreated and undertreated illnesses, and then the effects of just taking medications that don't work, and instead doctors just try higher doses. That also just contributes to side effects, movement disorders, all kinds of things that are problems with all the other antipsychotics besides clozapine.
Yeah, and I imagine this could be me speaking out of turn here, but I imagine that someone who is at the point of needing a clozapine or antipsychotic has also tried many other substances for other sorts of comorbid issues. And I imagine that just upping the doses on everything not only might not be as effective, but might also add to complications across the other medications that someone is taking. Again, not a doctor, so I'm speaking probably out of turn here. But
yeah, and Patrick, it even gets worse than that, because what we've found and what the literature shows is when one medication after another is tried and failed, then they just start combining them. Yeah. And we see antipsychotic polypharmacy that is not the standard of care being used instead of going to clozapine for cases of treatment resistance.
You mentioned at the beginning that you had a personal family incident with clozapine yourself. Can you tell us more about that incident and sort of what made you so passionate about pursuing the advocacy for this?
So there have been a couple major events related to clozapine. One was a REMS agency conversion in 2021, where a new program took over an old program and didn't automatically populate or transfer all of the patients from one program to another. This transition relied upon re-enrollment, doctors and patients dropping everything in pharmacies, recertifying, re-enrolling, and thousands of people's prescriptions were interrupted, including a family member of mine. And I was able to get some black market clozapine and probably save that family member's life. But there have been many more interruptions. I mentioned that I'm a legal guardian for a young woman on clozapine. She's had her treatment interrupted many times. She's in the community mental health system, and every time that she's been hospitalized, her treatment gets interrupted. In fact, one time, and this really upset me. One time she was refused clozapine upon admission to a hospital, and she deteriorated without it, so much so that she lost the ability to consent to a blood draw. And I, as her guardian, drafted a document. I requested, please just give her medication without the blood test. I absolve the hospital of all responsibility, and I accept full informed consent of the potential consequences. And she had been on clozapine for about 11 months. And at that point, the risk of severe neutropenia is minuscule. It's like 1 in 10,000. And at least of being detected in a single routine blood test. And they refused to give it to her. And they instead said, well, since you're her guardian, you can authorize a forced blood draw under restraints if you want her to have this medicine. And I about lost it. I mean, where is the compassionate use option for clozapine? Where are patients' rights to treatment? And then what happened, she was about a month away from reaching the 1-year mark where she would be eligible for monthly blood testing. But this interruption, by the time we got her back on clozapine, they made her start over with weekly blood tests for a whole other 6 months, right? So it completely derailed her treatment. And the FDA has authorized ways to waive labs that get missed, but no doctors are doing that. And I believe it is that fear of some sort of liability. I mean, I was told so many times that it was a federal mandate. Couldn't get this medication unless they submitted to these blood tests, which makes no sense. This is a life-saving medication. For the third of people with schizophrenia that have treatment-resistant schizophrenia, this is the only medication that treats that. Again, it's really similar to my insulin example. And one of the times she had her clozapine interrupted and another hospitalization, she got very sick with something called cholinergic rebound. She was vomiting and she had tremors, and that's another kind of withdrawal effect from clozapine. It's profoundly dangerous. There have been some pretty public deaths associated with pharmacies refusing to dispense clozapine on a Friday before they closed because the patient didn't get their blood test, and then that patient was dead by Tuesday. These are very serious conditions that this medicine treats, and it's not just for the patient, it's for the public and for the caregivers. 20% of SMI caregivers have experienced violence. So it's not just the patient that can get hurt if they don't get their medicine, it's other people. And mothers specifically are in harm's way often. You can imagine why they're frantically driving around town to find a pharmacy who will dispense their weekly ration of clozapine every week for their loved one. It's really a nightmare. And we didn't pick the name kind of picked us. There's a group of mothers so upset by this, they called us the Angry Moms. And we started this movement to end the clozapine REMS. You can go to theangrymoms.com, see a lot of our content, read our blog posts. We've been publishing a weekly newsletter on what we call Clozapine REMS Negligence of the Week. If you join the army of angry moms and sign up for that newsletter on our website, you can see what we're dealing with every week. They're pretty horrific. And what's kind of disturbing about all of this is that these are the patients that have an engaged caregiver. I've been fighting for this woman for whom I'm guardian and for my family member. I've been fighting to keep them on continuous clozapine treatment. And, it's an argument with the pharmacy. It's an argument with REMS. Sometimes it's multiple trips to the pharmacy or to the clinic. It's a lot. And we have families calling me in tears. They've been making phone calls all day. They can't get their next week ration of clozapine. And imagine the patients out there that don't have that. So I'm only seeing the patients with psychosis disorders who have engaged caregivers. What about all of those living in group homes and community treatment that don't have this? They're being interrupted all the time. And then even worse, being restarted at the original dose, which could lead to actually a black box event. So many, many patients don't have even access to this medication in the first place because they don't have a parent or a guardian that can run around town bird dogging these pills.
Hearing the story, and thank you for sharing it, it's sort of, when people talk about patient-centered care, this is an example of that. It's like, talk about how far we've gotten away from patient-centered care when doctors at times are so concerned about liability that they're making it not only impossible for a patient to get the treatment that they need, but also forcing families to go through the emotional toll of having to do the work of questioning whether or not the treatment is valid or effective or legal. The fact that you had to go do your own research to figure out if you could even legally get it in the way that your doctors were telling you is sort of like, kind of, to me, I don't know that it violates the Hippocratic Oath, but it sort of nudges up against it, which is like, is this really what's best for the patient? And I think it sort of like hallmarks everything that is frustrating about American healthcare right now. So, I appreciate the story, and it sounds like this is not an N of one experience. This has been experienced by many people. Can you tell us about how the Angry Moms, which I think the name is very apt, and I appreciate you going straight for the label. Can you tell us how that was formed, and maybe like what were the first connections that you met with other moms that had gone through a similar experience?
So there's some kind of national social media groundswell grassroots organizations. Team Daniel, running for recovery from mental illness. We've got a clozapine community on Facebook. We've connected through various forms of social media, and that's really where this thing started. One of our mothers, named a little woman in Michigan named Sue Maida, went to a NAMI conference and just got really upset about the trouble she was having getting her son access to clozapine. And I think she earned the label the Angry Moms. And then we just all joined her. We got some lawmakers involved. We got some other agencies involved, the National Alliance on Mental Illness, the APA is supporting us, Schizophrenia and Psychosis Action Alliance, a lot of organizations, even pharmacy groups. Pharmacists don't like this either. It's not fun to have to deny a prescription and watch a mother break down in tears. Nobody wants that. And it's this overly restrictive system that makes no sense. In fact, the FDA tried to fix it by announcing, quote unquote, enforcement discretion, which means you're allowed to dispense it anytime, but no one interpreted it that way. We're also in this world of a fentanyl crisis and opioid addiction, and many pharmacists have taken an attitude that clozapine is a controlled substance, and that, when in doubt, don't dispense, and that they'll get in trouble if they dispense without proper authorizations. And in fact, pharmacies are requiring more than what the REMS even needs to dispense a prescription. There in 2021, the system changed where you don't need to produce an actual lab. The doctor just has to enter it and sign it off in the system. But pharmacies are still requiring patients to show up with a paper lab in hand just to double check. There's also this idea that you have to wait for the blood test results to come back before you can dispense. And even that flexibility was granted, but no one's following it. They don't want to hand you your medicine until that ANC test result is back. And what if there's a delay at the lab? What if, sometimes these test results take a week to come back? What if the sample had a problem? What if you couldn't get the blood draw? What if you had a bad vein? I mean, all these things can go wrong. And the FDA's tried to put some flexibility in their program, but no one's following it. All these pharmacies are really holding up to the strictest letter of the law, even adding their own additional requirements.
And so, can you help me understand what was the start of the Angry Moms, or how did you get connected, and where did the nucleus form of that group?
So it really began with, I think, a partnership between NAMI and the American Psychiatric Association and the Schizophrenia and Psychosis Action Alliance. They had a listening session and they ran a survey, and they realized that this is a much bigger problem than it appears. We created the website. We had someone step up and donate those resources. We had a Hill Day at the Capitol where we spoke with lawmakers about this issue. And also we did an Angry Moms March on the Capitol with signs and angry mothers and patients. And it's just been a grassroots effort. We've got people joining our website, several dozen every week. We're now in the thousands. We have these blog posts that are well researched and informed, and we've got this newsletter going out. I mean, it's just really kind of shouting from the rooftops to anybody who will listen. Yeah. I mean, we're the ones having to live with these regulations and restrictions. The policymakers and the regulators just feel really detached from the reality of the illness and the reality of families.
Which I think is unfortunately the part that the families and the members of the community have to take, and it's never, it's never easy to feel grateful for something like this happening to you or the situation that you're experiencing, but it is an opportunity to, I think, help a lot more people. And I really am inspired by the actions that you've taken to actually get the word out and do the work of doing the research, publishing the articles, coming on podcasts, talking about it. What can other people do if they want to support, if they're compelled by your story, they're compelled by the research that they read on Angry Moms and that you're posting? What can they actually do to help support the mission and change some of these regulations around Clozapine?
So there's going to be a FDA committee hearing on November 19th. And we have created a very well-researched and intelligent proposal to end the Clozapine REMS and to update the product label to be more safe for patients. And we have put that in a petition on change.org. If you go to change.org/end the Clozapine REMS, you can read our pages and pages of research. It explains all the risks and benefits and hazards of the program, the truth about Clozapine-induced neutropenia, and a solid proposal for label changes, given what we have learned in the last 35 years since Clozapine came on the market. So again, that's change.org/end the Clozapine REMS. We would love a signature. We would love for you to share that, especially with families who've been afflicted with serious mental illness or suicide. And right now, we're just trying to get the word out, get support, and let the FDA know what our troubles are.
And we'll link to all the links here in the show notes for anyone listening. So you can just click there and support Rachel's work. I really appreciate this conversation, Rachel. I ask all of our guests the same last question. I think this one's going to be easy for you to knock out of the park. So if you could snap your fingers and change anything about the world related to healthcare, or in this case, clozapine, what would that be? What would you snap your fingers and do?
Well, first I would end the IMD exclusion and get more hospital beds for acute psych. The closure, the cost cutting, the removal of those services has been devastating to our country and to our families. Mothers are the new asylums. We've been forced into the role of doctor, nurse, security guard, hostage negotiator. It's just not safe. You can cut healthcare costs and people will die or be sicker longer. But when you cut costs for treating serious mental illness, it's a public health hazard. Other people are at risk. Caregivers are at risk. It's dangerous to society what we've done.
I love the answer. Rachel, thank you for the time. Really appreciate it. I'm really excited to get this message out.
Yep. Thank you so much, Patrick. I appreciate it.